Hello, everybody. This is Dr. Alice Lee. Welcome to iCubed episode 25. Woohoo!
25.
This is my second year anniversary recording. And I have Dr. Marc Zosky, who started this entire adventure with me 2 years ago.
I know, and it's so much smoother now. Our microphones are set up. We didn't forget to press play, so we're actually recording.
That is very true. So, 2 years ago when we started all this, when I asked you, Dr. Zosky, to come and join me, you were a baby attending, freshly out of residency, and now...
I am.
Oh, but no, 24 months later, you have gained 2 titles, I think. What else do you do other than everyday care?
I do it with you. The great Dr. Alice Lee and I do simulation medicine at the University of Arizona. It's a fantastic program.
Yes. Right, so you gain a title of a clinical assistant professor, just as I have. And there's another thing you do here at our practice. You're...
Oh, ultrasound director.
Yes! We had the pleasure of and the honor of having Dr. Wu head up our ultrasound program here, a little just to get all of us old dogs on the program and learning how to do POCUS. And then Dr. Marc Zosky took over the helm for that so that we can keep our skills up. So this time, we're going to talk about 2 cases. We're going to talk about 2 elderly people who fell. Have we ever seen those?
Never.
Never fall.
No. They're acrobats. They're like cats. They land on their feet with no injuries.
So we're just going to jump in. First case, he's an 84-year-old gentleman. He came in with his son and daughter, and he came in with complaint of right-sided rib pain after ground level fall. He's not on any anticoagulants. So the report was that he was in the bathroom, and he lost his balance, and he fell backwards onto his right side and back against the toilet. This is ground level, right? This happened about 4 hours before he came into the emergency department, before he was seen by me. Now he's complaining quite bitterly about severe right rib pain and right-sided back pain, and can't breathe without severe pains. We have a few minutes to look at his chart. His past history is pretty limited. CLL, hypertension, BPH, surgical history. He's had a total knee. He's got a pacemaker, and he's had a total prostatectomy. Medications are very limited as well. Amlodipine, citalopram, and aspirin.
I'm just shocked there's someone in their 80s on 3 medicines. That's it?
I know.
This is, wow.
So upon my first look at him, his vitals... the following. His blood pressure is 172 over 78. His pulse is 77. His respirations are 18. Painful. Room air saturation is 97%, and his temp is 97.2. What do you think?
They look good.
They look really good, yeah. On general appearance, he's a frail-looking elderly patient and male patient. He's sitting there. He's cooperative and he's conversant with me, but he's in a lot of pain. The son is at the bedside, the daughter's at the bedside as well. But you can tell he's really having shallow breaths and painful respirations. And the rest of his exam, I listened to his heart and lungs. They were really pretty normal. No murmurs, there's no rubs. Lungs, listening to his lungs, they were shallow and they were kind of mousy breaths because every breath hurt. On the exam of his chest wall, though, I didn't feel any deformity per se, but it was really, really tender, just with mild touch on the lateral chest wall. There was just a tiny bit of crepitus. I wasn't even sure I felt it when I touched his chest wall, but it was very tender, so I didn't really repeatedly touch his chest wall. But I felt there was slight crepitus, and it was very exquisitely tender. What do you think?
So how I always like to do these elderly falls is one of 2 things. I'm either... This guy would probably do more, but in my head in general, I either do very little. Do they just need a chest x-ray for a broken rib? And can they go home with a good social support? Or do they need to come in for like instead of spirometry out of that? Or do I think they actually have some multiple serious injuries that not only need a lot more extensive imaging than just like a chest x-ray, but do they need labs? Then I also think, what came first, the chicken or the egg in terms of, don't just call it a fall. Did they have syncope? Did they have cardiac syncope? Did they have a seizure? Did they have hypoglycemia? Did they have... What prompted them to fall? It's really difficult because some of these old people are like so pleasant, then they fall a lot too, so they chalk it up like, oh, I just tripped. I just was getting up and I tripped. And sometimes they're not really forthcoming with... Maybe they've been sick for 2 weeks. A lot of these, I mean, we've had patients out that come in as like trauma activations because they fall really bad. but they're febrile, and they're not hypotensive because they're bleeding to death. They're hypotensive because they're possibly septic or something.
Right.
So in this guy, with how exquisite his exam is, his difficulty with breathing, I'd lab him up and probably just CT him.
Right. So that's the beginning of that first patient. We'll jump into the second patient before we get any further.
I feel like this is an ABEM oral exam now. Now it's like moving on to the second one. The first one's labs are pending. We will get back to that in a moment.
All right, the second patient. Now this one is a 77-year-old female. She actually came in and triggered trauma B, and so in our level 3 trauma center in this community hospital, there's sets of criteria that qualify trauma patients for trauma A's and trauma B's. This patient qualified for trauma B because of the anticoagulant she's on, as well as the facial trauma. So she's a 77-year-old female who presents after falling on her face. She was going out to get her mail when this happened, and she reported she was on Pradaxa. She has a bit more extensive history than the other gentleman. Past history is hypertension, asthma, COPD, chronic AFib, hyperlipidemia, rectal bleeding, surgical history. She's had a total knee replacement, total shoulder replacement, total hysterectomy, thyroidectomy, rectocele, and cystocele repair. So a lot more extensive history in this lady. Her meds: metoprolol, amlodipine, Pradaxa, Lasix, vitamins, thyroid, pantoprazole, and simvastatin. These are very common meds for the senior citizens these days. Social history: she's never smoked, but she does drink daily. On general exam, she really actually looked much better than this sounds. She was talking to me, and she was pretty comfortable, I thought, but she smelled of alcohol.
Well, she's retired, She just relax during the day, have some cocktails, get her mail.
Yes, this was during the middle of the day, that's true.
It's beautiful Arizona, the weather's nice.
Yep, this is actually later in the afternoon, I guess, when she came in. So looking at her exam, her general exam was really pretty unremarkable on first blush, but when you look at her face and see the facial trauma, the entire left cheek was really bruised. Her left upper and lower lids are both very bruised and swollen. I carefully peeled her lids apart enough for me to be able to tell that her sclera was a bit injected, and she had double vision with upward gaze. So that's always one of the first things you have to check whenever you have any eye trauma, right? What do you think for this patient?
Let's see. CT.
Right, yeah, of course, CT. And some labs, right? And have to give her some pain medicine. So the studies for the first one came back. I want to show you what the rib films show. You can see very easily that there's rib fractures. I always rely on the radiologist because it's very hard to always tell exactly which ribs are fractured. But in this gentleman, I went ahead and CT'd him so we could see if there was any serious injuries deep inside. And here's a little segment I want to show you, and you can just take a look at that, and just on that right side, you can see.
Oh, what's that?
Yeah, you can see this, some air and some depression, and then you can see the lung itself. So the report from the radiologist shows the 5th, 6th, 7th, 8th, 9th, and 10th ribs were all fractured. There's 6 rib fractures. This is from somebody who fell against a toilet.
I know. It's always remarkable how much they injure themselves from minor trauma. 6
rib fractures, and there was a small flail segment.
I know.
There's a tiny little right pneumothorax, and then you can see from the image that I showed you that the bottom of that right
that's
lung.
A big deal for a guy in his 80s. This is
80.
This is high morbidity and mortality with an injury like this.
He's 84, and he fell against the toilet. So what did I do? Well, obviously I called my trauma surgeon, and our trauma surgeon on call that day was very gracious, and because the patient was adequately treated in terms of pain control and was very stable, he accepted the patient. He was stable overnight, but the next day the trauma surgeon felt the patient really required higher level of care, level 1, for possible rib plating. So all those ribs. Yeah, 6 rib fractures with a flail segment. That's remarkable to me. That's just for someone who's just in the bathroom, lost his balance and kind of smacked himself against the toilet.
And that's high risk just to give them analgesia, you know what I mean? They're already elderly.
And they've got pulmonary contusion.
They've got pulmonary contusions. Yeah. You don't want to overly sedate them and respiratory depress them, but you have to control their pain or they're just going to breathe so shallowly. Some places will even do like local nerve blocks around the ribs.
Intercostal.
Yeah, intercostal blocks.
For the second patient that we saw, the 77-year-old female who fell onto her face when she was going out to get her mail, and she was somewhat intoxicated.
Somewhat.
Right. But her labs came back, not shocking. The alcohol was a little bit high, 217.
Was that her baseline kidney function?
And I don't know, actually, but the MCV actually confirmed that she probably does drink every single day, as she told in the social history. Her H&H is pretty good. Her PT is elevated and INR is elevated. Kind of confirms that she probably was a very regular daily drinker. And the fact that she had alcohol was 217 and appeared as undisturbed as she was and unintoxicated as she was at the age of 77.
That's just called Tuesday right there, Alex.
All right, so I did the CT, I did a very extensive workup on her to see what was going on with her.
Well, it looks like a positive arrow sign on that CT right there.
So when I did the ocular exam, I suspected the entrapment because of the diplopia upper gaze, right? So this is the proof, if you will, or CT proof of it. She has a fracture of the left inferior orbital rim with a 6 millimeter displacement. There's a small amount of orbital fat that's extending into the superior aspect of the left maxillary sinus. So you can see where the positive arrow is. You can see where the crack in the bottom of the orbit is. And then there's soft tissue kind of protruding down into the maxillary sinus. And then this just made me shocked. This is her brain scan. Lots of positive arrows.
Oh, wow.
Remember, this lady is on Pradaxa. So we'll go through all of the findings. CT brain, there's a small amount of left frontal subdural. So she's got a subdural, as evidenced in the screenshot there. She's got a subarachnoid bleeding. So she's got a little bit of subarachnoid blood on this screenshot. Number 3, she's got multiple areas of brain contusion, most prominently involving the left frontal lobe. So you've got 1, 2, 3, 4 areas of intracerebral contusion.
And this lady's awake, alert, and having a good
She's
time.
talking, and lastly, she has a 3 millimeter shift of the midline from the left to the right. So she's talking to me, as calm as day, and just the amount of abnormalities on the scan was just, to me, such a shock for someone. You would not necessarily have expected that, except that she's on Pradaxa. Mm-hmm. So she was definitely a transfer because we do not have neurosurgical capabilities in our hospital. In the meantime, I gave her Praxbind, which was a relatively new antidote, if you will, or reversal agent to Pradaxa, which the patient
I've only given it once.
Yeah, I gave it once. This lady.
I see more Eliquis and Xarelto. I don't really see that much Pradaxa. I don't know why, but that's why I think I have only given Praxbind once. I think it's really expensive, too.
Yes, it is. So in her case, I did give her the Praxbind here in our emergency department, arranged for transfer to a level 1 trauma center. I followed up and looked at her chart. She was seen by neurosurgery, ophtho, and plastics. She did really well. There was no surgical intervention necessary. Apparently, the ophtho and the plastics did not find that she had any real significant diplopia or visual changes or restriction.
I forget her exam. She was the one that was already having severe swelling of the lids and stuff like that. Have you ever ultrasound the eyeballs before?
That's a great idea.
So what you can do if you're worried about a globe or a hyphema, that you don't want to really manipulate the eye much. And I've seen all sorts of stuff. I've even seen, I know the ophthalmologist, it's probably a manufactured device that's really cool that delicately opens the lids, but my attending used to use something called a paper clip. I don't know if you've ever heard of it.
No.
So he got this paper clip and would put it on the lids and pull the eye open.
Oh.
But what I would do is you just ultrasound the eyes, and you can follow the lens as your point to see where the eye is moving. And you can assess ocular motion with just the subtlest pressure from the ultrasound probe. In fact, you're not even pushing it. You're just making contact with the jelly.
Yeah.
So It's like where some ophthalmologists are really reluctant if you ever tell them that, you were concerned about a globe and you touch their eye.
Yeah.
Well, just the weight of the jelly on their lid is not really going to damage them. And then you can assess, do you have a nice spherical globe? Do you have full extraocular motion? But you can assess it while the patient's eyes are closed. It's kind of cool.
That's a fantastic idea. I should have done that. Why weren't you with me on that shift?
My precious days off.
Yes, exactly. Learning focus number 1. So,
Can I guess it?
Yes.
Minor injuries can have severe trauma?
No, that's too wordy and too complicated.
Oh, Praxpine. See, I can't even say. Idarucizumab.
That's pretty good.
Oh my God.
It's idarucizumab.
There you go.
The Praxpine, even though we don't really use it very much, I think it's important to have knowledge enough so that we can keep it in our armamentarium as ER doctors, right? We want to be able to choose the right agent for the right anticoagulant. So Praxpine only works on Pradaxa, which is dabigatran. It is, did you know this? It is a monoclonal antibody.
Yeah, it ends in umab. Umab.
Oh, really?
Yeah.
How interesting. Ab as an antibody. Mm-hmm. Oh, very good. Monoclonal antibody fragment.
Oh, there's a whole, I am not the expert to describe this at all, but for people that really want to get into the nomenclature of these, it is detailed how it ends, if there's Z's or I's, and it can tell you how it was grown, if it was grown in a human or grown in an animal cell, how it acts. Oh, yeah.
So that there is a logic to
There's
these
a method
names.
to the madness.
Wow, so MAB probably means monoclonal antibody.
Mm-hmm.
I get it.
Before that, depending on what consonants or vowels are in there, tell the story of how they manufactured it and what it came from. Oh, yeah.
Wow, very good. So it's a monoclonal antibody fragment that binds with high affinity to Pradaxa. It actually is effective within minutes. In the studies, apparently the hemostasis was reported as being improved without an actual increase in the thrombosis. So this is a little diagram I kind of edited from another diagram. It shows that the Pradaxa deactivates the thrombin, but then Praxpine comes along and attaches to the Pradaxa and then removes it from the deactivated thrombin and thus allowing the thrombin to become active. So, simple. Learning focus number 2.
Okay, I was wrong on the first one, so I'll let you pull the second one.
All right. This is a little bit more extensive and definitely more really directly applicable to our 2 patients. Geriatric syndromes. Have you heard of that?
No.
All right. Good. I'm going to teach you something. I want to give a shout out to Dr. Christina Shenvi. I fortuitously was at ACEP and went to one of her lectures. She gave a great lecture on geriatric trauma at ACEP 2018 in San Diego. So many of my slides are actually from her with permission. This is one of the definitions I found that was commonly used. Geriatric syndromes are multifactorial health conditions that occur when the accumulated effects of impairments in multiple systems of a patient renders a person vulnerable to situational challenges. There are multiple different geriatric syndromes. Falls, frailty, delirium, and dehydration seem to be very common ones, but then there's a list of other ones on the side of the slide here. I want to just focus on the falls geriatric syndrome for a short period of time. This is not an extensive, all-encompassing talk about geriatric syndromes, but because our patients were 2 very clear examples of the geriatric syndrome falls, I wanted to dive into it a little bit so that we can at least have some idea of what falls geriatric syndrome is. So trauma is the 5th leading cause of death in patients aged greater than 65. The elderly account for approximately 28% of deaths due to trauma. The elderly represent only 12% of the overall trauma population. So there's a disproportionate percentage of deaths from trauma due to the elderly. And these patients over 65 years of age, when they are admitted for trauma, these are the things that they're admitted for. 78%, as you see, is for falls when they get admitted for trauma. Then there's car accidents, which is only 6%, shocking. And then in terms of the demographics of gender, most of the elderly that get admitted for trauma are female. So
That's
70%.
so funny because under 35, it's mostly male.
Right.
Because we're the smarter sex?
No.
No, 'cause we make poor choices.
There you go. And these are all, you got to remember, most of these are ground level falls, right? Yeah.
Wow.
So then the types of primary injury in adults greater than 64 years of age who are admitted for trauma. So these are the three top types of injuries. So number one is lower extremity fractures. So that would be hips or, femurs, whatnot, ankles. And then number two would be neck or trunk fractures. And then number three, the third type, most common injury would be intracranial injury. So this is the scope of the problem. The adults age 65 and over are the fastest growing demographic. So like right now, it's 2019, right? So we're close to 2020. Back in 2010, there were 40 million 65-year-old and older adults in the United States. And that was 13% of the population. It is anticipated that in 2030, and that's not far away, that's 10 years from now, 20% of the U.S. population will be 65 years or older, and that's 70 million 65-year-old
It's
older.
going to be a lot of falls, Alice.
So this is really a very, very alarming, in a way, a very scary statistic. So these are all contributing factors to why the senior citizen will fall, and they're mostly ground level falls too. So they have this combination of acute on chronic illnesses. Wow. They have cognitive impairments, Alzheimer's, dementia, or just cognitive decline through their aging. They have medication and polypharmacy problems, right? How many of you mentioned it?
Oh my God.
We had one of my patients only had 3 meds. The other one had about 6 or 8, and that's the more common scenario, right?
And they don't know them half the time.
Right.
I take what my doctor gives me.
It's that purple.
It's the blue pill, doc, you know. Oh, the blue one.
The blue one, yeah.
Gotcha.
So the seniors have decreased mobility with imbalance. That just happens as they get older. They have a fall history. They've fallen before. They have sensory deficits. They can't hear, right? They have peripheral neuropathy. They can't see. They need glasses. My patient here has alcohol use as contributing to her fall. And that's probably more common than we realize, probably. Postural hypotension, that comes from dehydration. It comes from meds that they're on, Parkinsonian medications and such things. Depression, well, yes, a lot of the seniors live isolated lives, and the depression is, I think, a very significant part of it.
They really do. Their family doesn't visit them.
Yep.
All their friends have died.
Right. Or children die. Their children die.
Sometimes it's amazing how many actually live alone by themselves, because we see their physical abilities and their med lists and their medical problems. You would think, I'm actually fascinated. I assume sometimes, you live in a skilled nursing facility?
Right,
no,
right.
I came from my house.
Right.
Ma'am, you can't walk.
Right.
Oh, I do okay.
I do okay.
You can barely stand. Oh, I do okay.
That's true.
No, you don't.
Yeah, that's very, very true. Many of them use assistive devices, walkers, 4-pronged walker, or they use splints sometimes, or they have diabetic shoes. They have hearing aids, things like that. And there are environmental factors. Their house, how many times have you heard the medics come in and say, that house is just atrocious, there's stuff all over the floor. The seniors are like tripping over things, and over the cords and oxygen cords, right?
Even like basic stuff that we don't think of because we're ER doctors, so we do acute stuff, but like they'll send home health people to these houses to try to make it more fall resistant. These people will have multiple steps, multiple rugs that they can get their feet caught up on, shag carpets, all sorts of stuff that you never really think about.
You don't think about as young people that we navigate so easily through that kind of those kind of obstacles, but the seniors do not.
They have to augment. They can't get in their bathtub. Their sink is too low. Their counter's too high. Their cabinets are too all sorts of stuff like that.
Exactly.
This list is scary. It's like the perfect storm. I think I've seen people that have every one of these little arrows, and I don't know how I don't see more falls.
Well, I know. I don't really want to be scaring people, but this is the reality of geriatrics. I mean, we're getting more and more geriatric patients in all ERs, not just mine. I'm comfortable with them because I've dealt with so many geriatric patients, but I think that, across the country, there's and across the world, there's more and more need for geriatric services and knowledge of geriatric care. So that slide is certainly scary, showing all the contributing factors. This slide, I'm hoping to just put a little hope in your heart, my dear.
I'm nothing but an optimist, Alice.
So, the acute and chronic illnesses, you want to make sure that they have a PCP or a geriatrician. They can help maintain and be on top of their illnesses and their chronic conditions, right? If they have some kind of cognitive impairment, you want to make sure that they either is evaluated by a PCP and sent to a psychiatrist or a neurologist. Those would be the best resources for this condition. In terms of medications, polypharmacy, boy, it would be wonderful to have a geri pharmacist.
Wonderful. I just, and it's not these patients' fault so many times that they have so many chronic illnesses that they see so many specialists.
Yep.
And in today's age, the specialists prescribe their wheelhouse.
Yep.
And they often don't have a great geriatrician who's quarterbacking. So they're on tons of meds by tons of docs.
Right.
And they, I think their generation respects doctors as their word is golden.
That's right.
If they are prescribed, my take what my
Right.
doctor gives me.
Right.
Yeah,
the PCP's role as the general contractor, if you will, to manages all these meds, I think has been broached because they're asked to see so many patients.
Oh, yeah.
And they're trying to get through their day. And I think that it takes so much time with a senior citizen to go through their meds and making sure the meds are proper.
That's a 30, 45-minute office visit.
Yeah, exactly. Exactly. So that definitely is a contributing factor to the fall geriatric syndrome. In terms of decreased mobility and balance in the senior, neurologist is helpful to kind of assess the reason for falling. And then physical therapy can be very helpful to strengthen the frail senior citizen. In terms of just patient having lots of fall, a PCP would be helpful to kind of have a broad look at why a patient is falling and to refer to the appropriate specialist and category of helpers, I think. In terms of the patients having sensory deficits, the optometrist is helpful to make sure that vision is assisted with assisted device such as glasses. My mom just had cataracts, and it made such a remarkable difference in terms of her ability to be.
Oh, their quality of life.
Yeah. Oh, tremendously different.
Yeah, when they can interact with their family
right.
and not be just ignored because dad can't hear.
Right.
Yeah.
So the audiologist is definitely very helpful in that regard. Alcohol use, well, I guess to me, when you're 75 and drinking a lot, and you've been doing that for so long, I don't know, I'm not going to make any changes in the ER, but they could be referred on to the counselor or PCP to talk about their alcohol intake and see what they can do about that.
I'll bring it up. I'm like, sir, do you want to quit? Nope. Okay. It's like the person who's 85 and he's still smoking, and you're like, at that point,
right?
I'm not too aggressive at telling them.
Yeah, I agree. I don't get really too aggressive, but I think it's important to have a little bit of a discussion to point out once again to them how it contributes to their falling and their injuries, right? And then in terms of postural hypotension, there's some meds that do that, and then just some people are, chronically dehydrated and they get syncopal when they stand up. So that may be addressed by physical therapy, or an occupational therapist can get involved as well. And then people who exhibit depression, I think a lot of times we don't address it. It's kind of like an area that for me I don't want to touch sometimes because it's so multifactorial. It's very sad, and they're very sad. Yeah, we don't have the time.
That is a long
discussion,
and a lot of it. Some of the facilities here are not as good, and some are really, really robust in terms of like really big interactions with the community, so the senior doesn't feel isolated.
And then in terms of the use of assistive devices, referring them on to physical therapy again, and then maybe getting orthotics for those painful feet. And then environmental factors. I don't really know if we have anything in our hospital system or in our systems at all set up to go to seniors' homes to assess them.
Home health does that as part of their assessment.
Oh, I see. Well,
The end. 2 years in.
Wow. Yeah. My labor of love, and I continue to gather case after case after case in our very busy and very, very critical ER so that I can do more and more of these cases. But I've been having a great time doing these cases, and I hope that you guys enjoy it.
I enjoy it.
You enjoy it? So thank you everyone for listening again and watching my screencast. I would love to hear from you. And if I'm at a conference and you see me, come up to me.
She doesn't bite. A very intimidating 5 foot tall Asian woman.
I'm 5'3". Okay, anyway, thank you everybody for watching and listening this month. We will see you again in 1 month. Bye.
Bye.